Thanks, Paul. Can I just really quick, I know everyone's getting tired, I'm getting tired, so I'm going to go through all of this stuff pretty quickly and pick out the main points, and then we'll have time for some questions if there's anything burning that people want to know. I just want to quickly mention Erin and Reconnexion, not Erin specifically, but Reconnexion. As a pharmacist, I've contacted Reconnexion with and on behalf of my patient in the pharmacy before, and found it incredibly useful. And it was a circuit breaker for a patient that hadn't considered, didn't know, and it was a brilliant phone consultation that then led to a different pathway. So that was great. It's a great pathway, and pharmacists can also put people onto that track if they need to, if they see benzo use that they consider to be out of control or in need of some help. I also just want to mention Dacus. Paul said that he rang Dacus today, and I'm a frequent flyer on Dacus as well. I mean, it's a brilliant opportunity when you get a script or as a prescriber to just have a chat about some of that stuff that you might not be able to get hold of the pharmacy, you might not be able to get hold of the prescriber, and you just want some clarification about the drug, the pharmacotherapy. Dacus is a brilliant service to ring and have a chat to. Quickly, I want to talk about challenging conversations, and this can be a challenging topic, let alone conversation. But certainly from a pharmacist's point of view, one of the things I want to mention is something that Paul touched on, and that is the area that we have that conversation is also important. And again, I think pharmacists have become pretty skilled at realising that we are in a general space most of the time. So it's something that we need to be aware of, and we need to sometimes move people into a private area. We would discuss other things anyway. And I think we've probably over the years as pharmacists developed language that is appropriate if people are overhearing. A lot of us have consult rooms now, or just an area where we've got a lot of dead stock that nobody buys anyway, and that's always a good place to take people when you want to have a bit of a chat. So every pharmacy's got that. One of the things we need to do is avoid stigma. Again, Paul's touched on this, and it's so important. I run a pharmacotherapy program for opioid dependence and have for many years, and one of the things I learnt very early on in the piece is that two main reasons I lose patients is either to do with money or to do with stigma. And the stigma is really wide and varied. It's stigma about being on the program, it's stigma about being addicted, it's stigma about all sorts of things, and it can come from the doctor, it can come from the pharmacist, it can come from a myriad of different angles. But ultimately, what it does often is it pushes people away. And I don't know one treatment or one condition or one drug that we prescribe or dispense where our aim is to push people away from treatment. It's always about engaging. So it's not much use me dispensing methadone, but I hand it over with some sort of attitude that says, you did this, it's your problem, I'm not really interested, I'm going to give you the drug, but I don't condone it, I think this, and I'm going to make you wait. Everybody else, I do all of their scripts first, and then I do. If I've got that kind of attitude, then it's probably not the area that I need to work in, because I'm not really going to get good results, and I'm not going to get those fruitful outcomes that I'm looking for. I just want to quickly mention motivational interviewing. And motivational interviewing, I'm not going to teach you today, but if there's one take-home point, and I'm sure you've read about it and a lot of you employ it already, but the most important point about motivational interviewing for me is listening, because it's with listening that we really are armed with the sort of information that we need to help people. And if we don't listen, and if we don't understand what the problem is, you'll find that by listening, most of the time, a lot of the answers and a lot of the directions that you need to take are really being described by the patient themselves. So for me, it's all about listening. And we can use all sorts of acronyms, but in the end, we need to hear what people are saying, make some affirmations, some reflections, and some summaries around what we've heard and what we know is the direction that we really want to take that person. We've got another case study which we're really quickly going to have a look at. Again, that's a GP screen, but it's very similar except for those two tiles, permits and correspondence. I very rarely have to type any patient in because, as I said, because my software is all integrated, I just pop straight in, put my little code in, Okay, so there's my history. Here I can see my alerts. I can see the red alert. I can see the amber one. The amber one's slightly different, lower dose. It tracks 6 months, not 3. It's slightly different. Again, you can read all of this in the notes. Paul talked about the view access history. That's really important to me as a pharmacist. Of course, it is to GPs as well, but I'll give you one scenario where it's particularly important to me, especially in this early stage, because if I go into view access history and I don't see the doctor's name, then what I know is the doctor hasn't looked before he's prescribed or she's prescribed. Now that may modify the way I then go forward, because I then realise that I'm probably sitting on information that the GP didn't have access to for whatever reason when it was prescribed. So that might alter things in my eyes. Whereas on the other hand, if I see that the GP has gone in and has written the script, hasn't been anything else dispensed, there's nothing else that they may not know that I know, then I've got to make a decision. The GP's decided that that's okay. I'm probably going to agree, but I may not. So if I really think that there's a problem, I don't have to dispense it. And that doesn't mean that I'm just going to go solo. It might mean I make the phone call, have the conversation, discuss it with the GP, discuss it with the patient. But ultimately, I'm making a clinical decision as well as a pharmacist, and that needs to be respected. I think we've probably done this to death. I think that really the most important thing is to jump on and have a play with it yourself. As I said, it's pretty intuitive when you do that.